I don't mean that in an explicit way, like you're walking around with discomfort, although some people might be. What I mean is that the person says, well intended, if there's anything you need, right, I'm there for you. But the irony always of that with that is it's the performative, perfunctory, contrived,
how much
I'm
I
there
am.
for you.
Yeah.
Right. And it's
I'm
all
really here for
of
you.
alleviating my guilt because I'm not there for you. Welcome back, Dr. Kristian Kemtrup, Kiki, as we like to call you now. Thank you for being here again. Today, we are speaking to Trauma, Part 2, Electric Boogaloo, as decided.
Yes.
After the splash that the first episode made, I heard from the president and Elon and other celebrities reaching out about this debate of what is trauma and if they experience trauma. I'm actually starting analysis with
They've
trauma.
had some really traumatic things happen.
Yeah, they had a big breakup. Don reached out to me. He said, "I'm the greatest therapist." I got to work on that. It was pretty good. Was it bad? Should I edit it out? But we did get some traction of people, obviously as anticipated, having strong opinions about the definition of trauma, like we said, and what is or is not. How does it qualify? How is it useful clinically? Of course, if it's more specific in its definition or connotation, or if it's more inclusive, and should there be qualifiers or not? And then, of course, we demarcated the experience of pain, of quotidian pain versus the significance of uppercase T, I recall, trauma. And of course, then how to treat it, which is where people also commented. And are there appropriate protocols? What needs to be included or not? How does a clinician understand it? Should it be more didactic, interventive, manualized, what have you? These aren't pejoratives.
Yeah.
Or not. And so with that said, I'll give you the floor in terms of how you want to continue this conversation.
Well, I don't know. I mean, as you were talking, one thing popped into my mind that we didn't talk about in Trauma 1, and now that we're into
this is Trauma 201. Yeah,
Trauma 2, the re-traumatizing.
Yeah, the re-trauma
is a little bit like, think, even if it's, the different ways to define trauma, there's something at the core of what we're talking about with trauma that's undeniably real. And yes. I think one reason that's important to just say, and it should be obvious to people, is there are people, they sometimes go or get called anti-psychiatry or anti-diagnosis or anti-psychopathology, who seem to be of the mindset that there's no such thing as psychopathology. And whatever else I think we can glean from the notion of trauma is that it's a real thing that happens to people that makes it hard for them to flourish or feel happy or have the right kind of relationships for them. And that's a very significant thing, I think, that you can't deny the existence of trauma. And people who are anti-diagnosis and anti-pathology, who think that we shouldn't ever think of some mental states as being pathological.
Or pathogenic.
Or pathogenic. That's right. Yeah. I think that view becomes not just absurd, but pernicious when you just think about the reality of trauma. Pernicious. Yeah, I know that's the fancy way of like really slapping a view.
Yeah. I feel hurt. Yeah. I think it's a great place to start because in my recollection, which of course it's not bulletproof, I think there was no disagreement. Dare I say, we did receive positive feedback. I know, go us, that acknowledging the reality, the actuality that trauma exists, that it's, I don't know, scientifically valid or validated, yes, depending on, if you're positivist or materialist or whatever. It's not just this academic construct that we've invented in service of justifying or qualifying thoughts, feelings, behaviors. It's quite real, especially insofar as I think we might have touched on in terms of the neuropsych, that it passes go in many directions. And just speaking to basic, fundamental processes in the brain, nervous system. That encoding memory is the most obvious one, where it's not properly rendered into explicit long-term memory. And that seems to be well substantiated at this point, that your affect a limbic system, to be a bit reductive, and it's more complicated than that, I understand. Don't want to upset the cognitive neuroscientists, that it's disrupted, and then it percolates, it nags, it doesn't go away, as we talked about. It's not metabolized or processed, and so on, and therefore it is real.
Yeah, no, and I think there's ways you could say something that are overly simple or slightly wrong. Like I'm thinking of, Van der Kolk's book, The Body Keeps the Score. There's lots of you can say about trauma that have, some elements of the truth and maybe slightly off. But we do know that there are ways the brain is changed and affected, that there are ways we can study the neurological or psychological level, the reality of trauma as a process. It is a thing. And I think this is important. I mean, there's this movement, you can see it a lot online. I think it's kind of merging a little bit with the Make America Healthy movement from RFK.
The love of my life.
I say things like depression aren't real, or personality disorders aren't real. And I get that the level at which something counts as a disorder is a bit vague, but personality is real. And I think depression is real. But one thing we know for sure is that trauma is real. And the other thing I wanted to say about it is I think the reality of trauma and the scientific study of it, both psychologically and neurologically, is a really important development of 20th and 21st century psychology. It's not perfect, but a kind of success story. I don't think trauma was as well understood in folk psychology, just people's ordinary ways of thinking about how other minds work, until psychologists and therapists began writing about this kind of stuff. That I think is
documenting it. I think like we spoke to, from the 1,000-yard stare to shell shock. Am I getting that right? To
that's right.
PTSD. What was there one in between? I forget. After shell shock, I don't remember. Even just the acknowledgement of, and it wasn't 1,000. I forget. Is it 1,000-yard stare? Was that the phrase?
Sounds right. I can't.
And it's but just to see the evolution of the acknowledgement that these men would come home from war, especially we're speaking to early documentations from my memory include the Civil War.
Yeah.
American Civil War, and then, but of course, World War I being the biggest at the time, the Great War, and it wasn't seen until it was seen in mass. It had to reach some threshold in population, obviously, of so many men coming home, and they were not themselves.
Yeah.
And this is substantiating again the reality. I think it could be cool for today's conversation, and tell me, audience, if this is too lame or boring, but I want to play, if I could be Morpheus for a moment, who I always wanted to be. Not from the Matrix more so than Greek mythology, but maybe both. What is real? Maybe, I don't want to get too deep into the, metaphysics here, but what do you mean when you say that it's real, or what is important about the way you're saying it?
Yeah, I thought for a second, I used to teach philosophy, and we talk about the Matrix sometimes, and I would tell my students a bad joke. If there's ever some dude in like an old abandoned building and he's wearing leather and he holds out his hands and there's pills in his hands, don't eat either of the pills.
Yeah.
They're both bad.
Depends on what what kind of night you're looking for, I think. Depends on your version of fun.
Yeah, I suppose.
If you're consenting, hey.
Yeah. No, I mean, we could talk a little bit about the underlying reality of trauma versus different ways of trying to form some conceptual construct that captures the reality. The clearest example of that would be the evolving definition of PTSD in the different editions of the DSM. I think that's something interesting. That's construct, right? A way of trying to think of what trauma is and how it lives in the mind. But I think there's a way in which, with psychological phenomena, we have to recognize that the best way to understand them is to be a kind of pluralist about multiple different constructs, all kind of capturing the underlying reality in slightly different ways. I think it's very difficult to imagine having some scientific definition of trauma, some scientific construct that completely replaces a more simple folk psychological notion of it, or a clinical notion of it. We're going to have all these different accounts of trauma. It's not like one of them will defeat the other ones. We're going to have different lenses through which to see trauma. That would be my take.
No, and it makes sense. Again, the tolerance for pluralism, as we've spoken to, and others have spoken to on episodes here, that challenge is a meaningful one, but it's, again, kind of cliche at this point. The tolerance for multivariate causality, tolerance for the limits of language, of course, the tolerance for nosology not being the same thing as etiology, and again, the validity, the tests we use, and that it does such a disservice, as we discussed in the first, trauma 101, it does a disservice to the patient, to the
Yeah.
to the person who's in pain, and
Yeah.
saying this isn't real, or of course that's incredibly dismissive and harmful, but more even to say that this implication, I think that was also interesting that you brought up about it, that if it's psychogenic, it's not real. That also is this gross cultural illiteracy about if something is produced in the mind, it's therefore ineffective or benign, or I don't know what the word would be, inert and unimpactful, non-reactive, as if, you're stressed about your workday and it makes your blood pressure higher because you have a frustrated boss and you're in traffic and your coffee was the wrong order. I mean, it's just a reality that your blood pressure goes up or your heart rate goes up. But we don't argue that that's not real. But if it's psychogenic and it's a mood or it's trauma or it's a part of a personality structure, we say it's just in your head, which is a bit of a different conversation that maybe we shouldn't go to. I don't know.
I mean, it's worth mentioning that in all psychological phenomena, I think there can be a way in which it's not just psychogenic. It's not just things that have happened to you and your feelings cause you to become a different person with these different features. Like if terrible things happen to you, you become a person who has trauma. I think there's a way in which it's also culturally created, like the way that our psychological features manifest themselves is influenced by the culture. But that doesn't mean it's not real. Like, I think there's all sorts of evidence to suggest that multiple personality disorder, the philosopher and cognitive scientist Ian Hacking writes about this, is something that exists because there is a real neurological phenomena of dissociation. But there's an idea in the culture that if you have a lot of dissociation, maybe you've got multiple personalities. And that idea that floats around in the culture conditions how your dissociation manifests. It starts to become this notion of multiple personality disorder, which Hacking argues didn't exist before culture invented it. But that doesn't mean it's not real. Like the reality of something can be partially culturally created, and that's still real. I mean, marriage is a cultural creation, but it's still very real. Money.
You're telling me. Ask my wife.
Is a cultural creation. It's very real.
Right.
I do think, though, that these discussions about what's real and what isn't, in my mind, they often get used to, I don't know, be dismissive about the nature of clinical phenomena. That they often get used to change the subject and distract from what's really important about things like trauma.
Well, that's what. So before, there's a lot of bait there that I wanted to bite down on, but maybe first or predominantly I was going to ask you, what do you think, and again, there's no right or wrong, but what do you imagine or what do you think or what do you perceive is the motivation behind, of course, the person saying it's not real, or globally or culturally? If we say this phenomenon is not real, to me, it's just, to speak plainly or simply, it's a dismissal of something potentially threatening to my worldview or my relationship to reality. So by saying it's just in your head, or by saying it's not real, or snap out of it, or whatever it might be, it reduces and diminishes and swallows the qualities and efficacy and potency of something that could be, I don't know, dangerous or harmful or hurtful to somebody. So they disavow it. It's not part of reality.
Yeah, I think that's right. Whether somebody's kind of conservative and wants to have a moral framework for all of this, like you're not traumatized, you're just, making it up. You're just being lazy. You're just being avoidant or something. Or which happened in World War I. You're just demoralized. You need to just buck up and go back to the front lines. That's, people heard that, right? And people nowadays with trauma hear that from their family members sometimes.
Right. I was going to say, so even, or I think of the during the Iraq War, under Bush 43, I remember certain 60-minute episodes or PBS episodes. I was relatively speaking, very young, but I remember those. It became part of the zeitgeist, the conversation about PTSD. In my recollection was big time in the early 2000s. It was like the first time being acknowledged as people coming home from Afghanistan and Iraq, late in early 2000s. Long story short, there was also the fetishization on the other side, which is to say that the acknowledgement of PTSD was real, but it was still that I don't know how to handle this. This makes me uncomfortable. This still confronts my worldview, my reality testing, my perceptive biases, what have you. And so because it's only those people and those families have to deal with it, and of course the government not supporting. We understand at the time, to this day, military after the fact, military men and women. It almost was like two sides of the same coin, where instead of saying it doesn't exist because it's all in your head, now we're saying it does exist, but it's still all in your head.
Yeah.
And snap. And it's like, you have to go to the VA and take these, you'll be fine type of thing. And we're just going to pretend to put it under the rug. It's like, it's trauma. All of this is to say, like, trauma on all sides. We've really like come a long way, and to be a bit optimistic from even just 20 years ago when you're reminding me today.
Yeah. Well, no. And, in the anti-psychiatry movement, I guess what they would have to say about trauma is, sure, bad things happen to you and you deserve to have a world in which those bad things are happening to you. But if we just improve your environment and we take away the bad stuff, the violence or the abuse or whatever you're suffering, then you should be fine. Because it's not like the stuff that happened to you has caused a pathological problem in you, because there is no psychopathology. We just know that I think that's as cruel a thing to even imply to somebody as a World War I commander saying to somebody, you got to get back on the front lines because you're just a coward, not traumatized. I think it's the same phenomena. And what causes it? An interesting idea about psychoanalysis is, I think you see this throughout the history of psychoanalysis, that there's something about the mind and what can happen in it that's not just something that's scary or difficult, like running out of money or getting sick. There's something in us that I think we're disturbed by, that is just overwhelming. And the idea that somebody could become more that way, I think our minds just recoil from that in these intense ways. And so you see in all sorts of different political movements, conservatism, leftism, some sense to just be in denial about how disturbed our minds can get.
Yeah, it seems shared, again, regardless of the spectrum is a circle, quite obviously, and politically, or just a moral spectrum and a moral landscape, and it's in three dimensions as well. It's uncanny how uncomfortable we are with the annihilation anxiety, right? It's so much of it is, in my understanding, again, although of course you can pivot to separation anxiety, and we could speak to the affective neuroscience, these things that are quite tangible that mediate these phenomena. But moving away from that and to speak to the more the phenomena itself, or the experience of it, is really to say, like you're saying, that it's uncomfortable for people to face, what do we call it? If you don't want to say annihilation, such a big word, mortality, fragility, the temperamentality, the vulnerability, the amenability of the mind. And so somebody who was so strong comes back again, and you really jogged my memory. I have the visuals of these episodes I remember from, I don't know, high school or something, of these documentaries with these poor men and women coming back from this war, and not understanding what they were doing there at the same time. So purpose plays a role too. And there was no way to metabolize, to continue that metaphor, what happened. And they were there for 9 months and lost a limb or something, as a common example. And the way they were treated was, as you're saying, it's so cruel, the way that they could be objectified by doctors, by the media, by their families, by the misunderstanding. I think there's plenty of evidence from, again, I'm trying to jog my memory as best I can, that it was the group support that was always the most effective and fruitful, because it was the knowledge, the epistemic argument. It was the knowledge gained through the experience of that ambiguous loss and pain and profound suffering that couldn't be internalized and worked through and grieved, and sharing that with others who experience it helped them more than the family, or help them more, according to self-report, than the psychotherapist, or help them more than giving them a stipend from the Navy or the Army or the Marines.
Yeah. Yeah, I guess two things. One, addressing what you're saying, and then also maybe moving us to something new. As you were speaking, you were coming up with these synonyms like vulnerability. I think going back to the first episode we did together, breakdown, I think there's something about...
Right, I had that. I didn't want to say it because then I felt repeating ourselves. But yeah, fear breakdown. I thought of it too.
Yeah, like there's, in people with extreme psychosis, in people with trauma, there's a breaking down of the mind. And I think we're so horrified by that instead of just being empathic about it and trying to see there's something real here in us and in these people, it's always possible in us and it's happening in them, that instead, there's this reaction to act hatefully, to destroy anyone who's showing signs and reminding you of breakdown or the possibility of breakdown. It's a kind of hatred of breakdown, a kind of phobia about it. And it's really quite disturbing.
It reveals a lot about our culture and that we all share in that. I'm reminded again. Well, you had a second thing to say you wanted.
Well, I think one place to go next, and I want to hear what you're going to say, is how much of trauma is the event versus how much of it is what happens afterwards and how it's discussed and reacted to. And I was thinking particularly also about Ferenczi's remarks on this in Confucius.
Well, right. So we can certainly move to that difference between the catalyst versus the experience of the catalyst.
That's right.
Where I always end up speaking to philosophy, or ontology and things. What I was just going to say is just working with patients through grief of any form. And, again, as we've spoken to, where all therapy is grief work, and this idea that there's something like a type of therapy that doesn't involve loss, and to develop itself, to change itself requires loss, requires grief, requires mourning of a certain, to move from A to B. And so I think of being there is on my mind, and the discomfort that we all have.
Yes.
In the speaking cliche, or to speak like in a movie or a show or a television show, where we're all uncomfortable at the wake, at the funeral, sitting Shiva, whatever it might be. And I don't mean that in an explicit way, like you're walking around with discomfort, although some people might be. What I mean is that the person says, well intended, if there's anything you need, right, I'm there for you. But the irony always with that is it's the performative, perfunctory drive.
How much
I'm there for you,
yeah.
Right? And
I'm
it's
really here for you,
alleviating my guilt because I'm not there for you, right? Negation in the unconscious, obviously, and so it's very powerful in the context of PTSD as well, because to be there with somebody in attunement, in the qualities, in the nourishing environment of just being present, not having to say anything, as an example, not having to bring the green bean casserole, as an example, not having to just pick up the phone with something to talk about as a distraction, but rather pick up the phone to just listen. We're so averse, like you said, we are so afraid, and it seems inherent, it seems universal for all of us to be there, to be in it, to have blood in the water, skin in the game, like we said. And I think funerals are such a powerful example of, and it doesn't have to be a traumatic loss. It can be a loss, a sickness,
more manageable one,
more manageable one, or old age, whatever is more common or accepted culturally. And we are terrible at it on average. We, as a group, as human beings, we are terrible at being with our fragility.
I was thinking too about parenting. Kids have, these states that they get into that aren't just tantrums, but they really start to fall apart. They start to have a little bit of breakdown. And it takes real effort and skill, and sometimes repression of yourself a bit, to not just angrily snap at them to tell them to stop. I mean, to really just bear their breakdown or what looks a little bit like their developing craziness is very, very hard to manage. And you see, I think it's universal for parents.
The idea that in the previous episode just published with Dr. Eric, Dan was just talking about, right, the screen as the mediator, the iPad, right, and just that it's as the parent neglects, myself included as a parent, that the iPad is as much for me as it is for the child. And we say, oh no, it's for the child. They'll listen. I could get the dishes done. I get the laundry done. I could get work done. We're not speaking to kind of an overt neglect or something completely pathological. That's not what we mean. It's just to say that there's a dialectic, as always. And so if I don't want to feel that anxiety of the breakdown of the tantruming child, then I'd rather give them the lollipop and Cocomelon and neutralize that. And then I feel safer as well, or I feel more effective. I don't have to tolerate, let's say, my own inefficacy or my own anxiety about being impotent or whatever it might be.
I want a lollipop and to watch Cocomelon.
Yeah, so do I. It would be really wonderful. I mean, it'd be different than Cocomelon, a different show, you know, but yeah.
No, to even
Still would like an iPad and a lollipop.
even talking about these things in the abstract, I can see it in, classes with classmates or myself, like reading a paper about traumatized patients, even one that's written quite abstractly. There's a way in which you can feel your mind recoiling at how hard it is to read about, extreme trauma, and not just the events of what happened, but like kind of what's happening in the person. It really is hard to bear.
To bring it back to what you were saying before with Ferenczi and the demarcation between the catalyst or the event and the experience, certainly in most orientations to psychotherapy, as far as I understand, or maybe I can't say most, but certainly many, having to reprocess is a phrase that's used. And I think of the work I've done analytically or psychodynamically, what have you, with patients who suffer from forms of how I've been qualifying it, capital T trauma. And like you said, feeling in attunement to what lies beneath, what is going on underneath or behind the absolutely necessary dissociation, derealization, depersonalization, intellectualization, compartmentalization, repression or suppression, and to start to get a hint as to what's going on through, again, implicitly, it's not stated in a symbolized in language, far from it, but you feel or you can see it on them. It's starting to come up. Tends to be bottom up is the phrase we use. And you see it start to emerge just a little bit and enter into some preconscious state, and the body reflects it. I can think of people who get flush, right, in some form, or their eyes well up, or their body language shifts and they're starting to get fidgety. And there's all these, and those are obvious signals. So there's obviously much more implicit or subtler ones. And again, like you said, just being there and helping organize the response based on a personality or temperament versus the event. Of course, it's very challenging to say, I'm also in it with you, or I'm rendered impotent by it as well, to some degree. I have to tolerate my sense of inefficacy to the monster that is this internalized experience that's still robbing you of your vitality.
Yeah.
There's a huge amount of humility.
Yeah. Childhood trauma, I think in particular, but I think we could talk about adult trauma too. I do think, and my clinical work bears this out, like Ferenczi, and maybe we should say a couple of things about the Ferenczi paper in a second, that obviously awful events like the unexpected death of a loved one, violent abuse from a parent, sexual abuse from somebody in your family, all of those things, the driver of later problems in development. But also how those things are discussed, talked about, related to by others around the then developing child in that environment. That is a major part of what happens going forward and whether it really pathology occurs. And I think this is one of the things Ferenczi mentioned. So maybe I should say something about the Ferenczi paper.
Please.
Ferenczi was Freud's, students, proteges, disciples is the right word.
Acolyte, disciple.
Yeah.
Yeah.
And Freud goes back and forth on this, but eventually developed a position that a lot of the claims, particularly of sexual abuse or of abuse in general, that his patients were reporting had more of fantasy in them than reality. Right. Like that seems to be a move that Freud pushed in. And one of the things that Ferenczi does is he realizes and then writes a paper about this. I think it's in 1933, so still a long time ago, where he kind of calls Freud out on this. And he says, it just doesn't make sense when we think about the amount of these reports that we're hearing from our patients to say that it's in their heads, that it's fantasy. I think this is really happening. And I think I've got an account of how sexual abuse and other forms of like abusive treatment from parents or caregivers to children causes a pathology that I see a lot of in my practice. And this paper actually got, I think in the US particularly, not enough attention. Ferenczi's work in general didn't get enough attention for some decades. But I think over the following decades and now the following century, I think there's more and more of a sense of how right Ferenczi was, that a lot of psychopathology is caused by, bad events in childhood, not enough of the right kind of attention towards those events and the impact on the child in childhood. And some of Freud's ideas about childhood fantasy, that might be less involved in the development of psychopathology. And one of the concepts that Ferenczi has in this paper is children live in this world where their language and their mindset is one of tenderness and fantasy and imagination. And if an adult comes in with this other language of sexual passion or something that we'd associate with being very adult, or with violence, the mismatch between those two things causes a need in the child to figure out how to manage this situation. They may be fantasized in some ways about being married to mom or dad. But now if there's sexual abuse, or married to an adult, but now if there's a sexual relationship imposed on the child or a violent relationship imposed on the child's psyche is thrown into chaos and they need to come up with some new way of managing. And long story short, one of the ideas Ferenczi comes up with is children in that situation will engage in something called identifying with the aggressor. They'll need to find some way of managing the aggressor, of complying with the aggressor, sometimes even developing some part of them that believes what the aggressor believes about them, that it's their fault, that they're guilty, that they deserve this. And all of these different ways of identifying with the aggressor are really the larger cause of the more serious consequences of psychopathology. And I don't know if Ferenczi gets all the details right. I mean, it's also a very vaguely written paper, but I do think it was like an important moment in the history of psychology and psychoanalysis, that it's not just that something bad happened to a kid, something violent happened, like they were in a car accident or someone hit them. It's how that's followed up that really is what causes a break in normal development. But I wondered what you think about.
Well, no, I mean, the demarcation between, again, event and experience thereafter is really important. Obviously, the tension there, the back and forth. It's, again, when thinking of how what's it called, ACEs, or the
childhood
adverse child experiences are measured, and what's not included, of course, is how it's cared for after the fact, and that can be a hell of a constructive force or neutralizer or even a healer if, like you said, a car accident occurs, but the parents are attuned to the child for years later in helping the child learn or grow or heal from it, and even mourn something like a broken bone that could have an effect later in life. That seems very valid and reasonable and meaningful. I'm interested, one thing in particular that you brought up was also this ratio was Freud implying, you maybe know better than me, that fantasy in this ratio for tolerance or integration of reality, if you're 100% fantasy or 99% and 1% reality, certainly we understand that psychosis involves in adults or children, that intolerance and rejection, of reality. In the Ferenczi critique, is he's saying that that Freud's connotation of fantasy, I know that word is also, PH versus F, also different connotations. Is he saying that it's not real again, to bring it back to that, or is he saying it's not? I don't quite
that what's maybe, not well. I mean,
that the fantasy isn't that Ferenczi's saying to Freud that he doesn't have it right because the fantasy is not what it's not.
I think that what's pathogenic,
right,
he wants to say, is that children, when they're in this mode of tenderness and needing the language of tenderness, they have developing a barrier between imagination and reality. So they might imagine a union that's physical, a kind of marriage. And you might even see it in their play. That's the language of tenderness. And Oedipal feelings can be found there. What's pathogenic, though, is if an adult comes along and doesn't treat the child as if that's what they need, but actually imposes a more adult language of you need to gratify me sexually, or we need to have a real adult relationship together, or I'm aggressive and violent, and you now, you can't just fantasize about hitting your dad or fantasize about hitting someone. You now are involved in the reality of being hit. And that's no longer a place of tenderness. It's a place where you can't go through that childhood developmental stage where you live with fantasies that help you manage aggression and sexuality and the difficulties of the world. That bubble, that distinction between fantasy and reality is collapsed too soon, which causes you to need some new way of orienting to the world, which is the source of a lot of pathology.
Wait, so let me ask the dumb question then, because maybe this is where I misunderstood. Is Ferenczi saying that Freud disagreed with that?
I think so. Yeah.
So can you explain again? So where did Freud disagree, I guess is my question.
I think Freud's idea is that the fantasies themselves are things that have a kind of perversion, right? And if the parents don't help the child manage the fantasies,
I see.
pathology. So the fantasy itself has a kind of riskiness and badness in it, and parents and the environment need to help you overcome that to become a healthy function.
So it's almost to the exclusion of, again, the same argument, intrapsychic versus interpersonal.
That's right. Yeah.
Okay. And nowadays we know it's both and.
It is both. That's right. I mean,
right.
This dispute between them, they're both trying to get at something right. But I think what Ferenczi is important for really introducing before and separately from this avenue we talked about last time of how during wartime psychiatrists helping people. Ferenczi is, I think, important for seeing what happens in families and how there can be trauma there. And that it's the trauma and the follow-up of it, how it's responded to, that causes a lot of psychopathology. In particular, if there's a parent who should be feeling guilty, maybe unconsciously does feel guilty about what they did to the child, hitting them or not protecting them from sexual abuse or causing the sexual abuse, that guilt, instead of the parent kind of dealing with it on their own and then helping the child recover from what the parent did or didn't protect them from, the parent introjects guilt into the child by talking to them in a certain way. And we see that all the time.
Sure.
And I think that's Ferenczi that points out that this is what we need to be talking about. And we shouldn't actually jump to the conclusion that Freud seems to jump to, that a lot of patient reports of abuse maybe are themselves fantasy, not reality. Ferenczi seems to think, no, this is very real.
It's again, right. It's again having to substantiate or validate, not in the contemporary connotation, but in the connotation of validity, that these things are, again, both and all the above. And you can't exclusively claim to the disservice or detriment of the person that this is intrapsychically generated entirely or the other way around. And we have to tolerate the pursuit of, I don't know, psychic truth, the pursuit of ontological truth, or, what's going on. And what you said before is so valuable in understanding this, where, again, we tend to be intolerant of not only this ratio between reality and fantasy and how that evolves normally or on a developmental curve. And, speak very plainly, you see your parents as human beings, at some point in your 20s or 30s, or maybe even teens sometimes, depending on the parent and child relationship. And then also, like you said, that how we manage that grief or loss or fear of experiencing them that way, which can be incredibly painful. And it can be traumatic depending on the dynamic, the loss. And it's something, again, that seems underappreciated or underspoken or undervalidated. I don't know, that this is a significant, causal variable in how somebody manages their lives if they're seduced or almost intoxicated by their own animating fantasies, and those have to be breached. I think, just to put a button on it, I think of, again, what you're saying, identifying with the aggressor. My understanding in terms of, the phrase is so lame, evolutionary psychology, and I don't mean it in the kind of the way that people study it now. I more mean to say that the evolution of our development, and that the child is dependent on the primary caregiver, and that's ought not be controversial. We are utterly dependent. I do think of it evolutionarily on the global scale or a large scale, longitudinal scale, where that tension between bipedalism or bipedalism and the size of our heads and gestation and obviously delivery of a child. There's all these competing forces as to why gestation for human beings is 9 or 10 months, and all these theories. That's all to say that we're dependent. We literally would die. We cannot survive without the caregiver.
That's right.
Feeding us and changing us and providing us, all the psychological needs as well. Identification with the aggressor, among the many other coping techniques of the child, makes so much sense, which is to say, I have to be the bad person and internalize that aggression or identify with it, because I have to protect myself, not only from being hurt physically or sexually, what have you, but also from the severance, the severing of that attachment, which I'm utterly dependent on. So I can't tolerate this object, this superhero that I'm dependent on, as bad. I must be bad. I must be deserving of this trauma or this pain. And that's also, in my experience, again, just speaking anecdotally or a bit at large, is something that's also misunderstood by the culture, that we can internalize those things very deeply, and that can qualify as a trauma, certainly. And it can certainly, again, get in the way of meaningful and authentic development, because I'm the bad person. And that relational template follows me for the rest of my life.
I think that's right. One way I have of putting it, and I think it's very simple. It kind of captures a lot of, I think, what Winnicott was trying to say, and a lot of what Ferenczi is trying to say, and Freud too, is that if you're in an environment, especially as a kid, where you depend on people, but something has happened that's so awful that you can't figure out how to depend on them, or you begin to perceive that the very people you're depending on are the problem, either because they're the cause of the trauma or they speak to you about the trauma in a way that just makes it worse, that your only option is to let that completely disorganize your mind, where you become psychotic, I think, or to comply. And compliance, I think, is the sort of thing that Ferenczi's talking about. Compliance could be, this person says I'm bad, so I'll just believe that I'm bad. This person mistreats me, so I'll just, think of myself as deserving of the mistreatment. Or maybe I'll even do that to myself. And that kind of compliance, I think, is the source of a lot of psychopathology.
And that compliance is a bit of a euphemism, right? I mean, it's true. At the same time, compliance involves self-sacrifice, tolerance for profound amounts of psychological, emotional, physical pain, compliance of all sorts that bends us into a position in avoidance of breaking us, as you said. It's quite powerful.
You're right. The way compliance is the wrong word is it sounds agentic. I might choose to comply with the jerks at work so I can just get a paycheck. But this kind of compliance in the face of trauma or childhood trauma is not chosen. It's a sort of mechanism that comes into play that
right, it's totally unconscious and it's automated, and it's so challenging to work with patients, work with ourselves, work with, again, the culture at large, and saying that it's non-consensual compliance, so to speak, and that is traumagenic. It's something that, again, back to where we started today's conversation, it's that trauma is real. And, the gatekeepers that are saying either it isn't are doing a huge disservice, obviously, to that reality. But then the gatekeepers that are saying everything is trauma is also doing a great disservice in speaking to these examples, especially in the context of dynamism, development, the liveliness of relationships that actually play a role in that tension between, as we said, intrapsychic pathogenesis versus interpersonal or relational, and tolerating, as we always come back to, all of the above, which is very fucking hard for the patient to understand themselves, for the practitioner to hold on to all of that at the same time without collapsing it into some sort of split or blame, which is super convenient.
Yes.
We're seduced by expedience all the time, and being okay that there's that it's real, even if it's a more inclusive term than maybe we're afraid to admit it is.
Yeah. No, I mean, ambivalence is the right word, because the kind of compliance, or for lack of a better word, that we're talking about is actually a very good thing. It saved the child, the person who suffered trauma. And on the other hand, it's also the cause of a great deal of their problems at the present time, right? And it's very hard, I think, to feel that and to understand that, to wrap your mind around the very thing that saved you is also
it's the ultimate analytic cliche, right? The very thing that saved you is now killing you, or that kept you alive, you survived at the cost of living, is another way I've heard it. And it's something that seems so ass backwards to people, and yet it makes total sense in terms of understanding how developmental needs, push on us.
And I guess we were talking about denying the reality of trauma. I don't think there are many people who would want to say that so out loud, right? That might be an implication of their position, but there are a lot of people who explicitly will say, we deny the reality of personality problems, we deny the reality of things like depression or anxiety problems. The society can be bad, but there's nothing in the psyche that's pathological. But I think if you believe in trauma and you have any understanding of it, you have to understand that what it is that it leaves something inside of you that creates problems for you down the road, that causes you to suffer and is therefore pathological, right? That pathe is suffering. That, I think, is a really important idea. If you believe in trauma, you believe in psychopathology.
Right.
And that word is not necessarily stigmatizing or demonizing, and that a lot of the things that psychopathology talks about, even if we have trouble, figuring out exactly how to define depression. Is it actually a bunch of different things? We have trouble defining PTSD. There's the DSM definition, but then there's the more psychoanalytic notion of it. There are more somatic notions of it that I shouldn't shit on too much. They're actually kind of interesting, the somatic ideas about trauma. All of these things are to say that I think once you accept the reality of trauma, you have to understand that things like psychotherapy, psychopathology, psychiatry, diagnosis, these are valid pursuits and important ones.
So is there in echoing what you're saying, what I'm struggling still, even though I graduated to Trauma 201 at this point, with how it's used both, I guess, when it's diluted, like we talked about, but also when it's negated or denied. I struggle with, like, I don't want to harp, but I struggle with that trauma-informed phrase still. I guess we were speaking to it in the context of marketing, maybe, or in the context of saying this is what I practice. But there seems to be, if I were to have a trauma-informed practitioner on another episode, they would have a way to justify, presumably, or qualify what they do that's different. Maybe we covered this a little bit in the first conversation, but I'm still struggling in saying, what is different? Is it just the modality? What makes that phrase needed? In saying, in the context of the conversation we're having today about it's real, psychopathology is real, trauma is this thing, even if it's nebulous, that does inherently have pathogenic qualities in terms of the whole psyche. Is there something, I feel like I'm still missing something almost?
Yeah. It's a good question.
I fucked you up.
Here'll be a shot fired. I think.
Oh boy.
Yeah, get ready. I think anybody who thinks that trauma can be treated in 16 hours, right? A really long plane flight, which is like a annualized length of a manualized treatment. Anybody who thinks that trauma is fully treated by going through some procedure that involves tapping or blinking and continually going back over the events of what happened. And those things can be good. 16 weeks of treatment is good. And perhaps EMDR, the tapping and the blinking, perhaps it is helpful to people. But anybody who believes that that's a kind of full treatment of trauma, I think is in some degree of denial about how, if you have trauma, especially during childhood or earlier in development, when you're a young adult even, that gets woven into your personality. That trauma treatment and a relational treatment that works on tweaking or modifying different parts of your personality, I think are interwoven. I think the idea that we can sever one from the other is a big mistake. And in fact, in kind of denial about how significant trauma is.
Well, it seems, again, treating a symptom as if it's the symptom is separate from the self, as we always say, okay, or that as if it's immune to a personality, that the anxiety is arbitrary, or that its causality is meaningless or without information. Of course, there are treatments that seem effective, as far as I understand, in terms of symptom reduction. But obviously, the mutative agent, the change agent, what the therapeutic action would be debated. And Dodo Bird verdict comes to mind. And is the EMDR tapping, that blinking stuff working, or is it the relationship? Well, the iatrogenic components, blah 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 blah. But I guess moving away from that hot topic is my tolerance with borderline confusion and curiosity, all at the same time, for how to negotiate this, given its both and, or given its complications, or given its complexity. And that I'm imagining, again, this nebula, this cloud that is misplaced in some location in the mind or the brain, the psyche, what have you, and it's producing this, again, it's pathogenic, psychopathological, and it's nagging at us, it's eating at us, it's getting in the way, it's interwoven, like you said. It's not, it's like it's metastasized in a sort of, it's like a lesion in the psyche that continues to produce the fever.
Yeah.
We're trying to excise it, psychotherapeutically or pharmacotherapeutically, what have you. And so it's no longer generating that suffering. And that, to me, is, again, I don't know why I feel almost to say uncomfortable myself in this very moment of being like, is that controversial, or am I not understanding something, or what am I missing in terms of this debate?
I think for you and I, it's not. controversial. I think we after all of our clinical work, we have some sense of how to think about this. And I don't want to be too arrogant. Maybe we're wrong. Who knows?
Yeah, no, that's what I'm holding on to this as light as I can. It's a helium fucking balloon, man. I'm not trying to stir any shit. I'm saying genuinely, it's very it's very real. Back to what we're saying. It's very meaningful. It's important to validate, I don't know what the word I'm looking for is.
Yeah.
It's there.
Every experience I've had suggests to me that, with the exception of some things that are kind of recent single event traumas, like, I don't know, a really bad, you saw somebody pull a gun on the subway and you just, you can't think about it. You find yourself frozen. Happened just a few weeks ago. That's the kind of thing I think that maybe could be treated in 16 weeks. You just get comfortable talking about it. You start to feel better about it. But
and you have the framework and faculties there already. You're sort of psychologically healthy, quote unquote.
And I don't see many cases like that. The kind of cases of trauma I see, it's been something that's happened regularly or a long time ago. It's awful. The follow-up in the family and people are, it was bad. And what I'm treating is not the event and getting a person to be able to tell me the story of their event so that they can finally do that. It doesn't involve tapping or anything like that. It's really realizing that it is kind of like a metastasis, like a metastatic cancer that has gone everywhere, or at least all over the place. And the treatment isn't really excising it. I think that's a fantasy. I don't think you can excise trauma. I think that's a fantasy that makes sense, that people would want that fantasy. Just cut this out of me. I don't think we can do that. I think all we can do is to grow the metaphor a bit, improve a person's immune system so the immune system can start to digest the cancer cells, to start to eat them. And it's an imperfect and probably never fully finished process in many cases. Especially
when we're acknowledging the reality again, that it is interwoven, interdigitated, like what's a better word, ensnared. It is a part and parcel of the building blocks of that one, of the person's psyche or personality or soul. Just to say, the way they function, the way that they operate in the world, their way of being, the way they relate to the world, to themselves and others, is not just informed. It's not a strong enough word, but it's determined. It's by the trauma. It's organized by the trauma. It's mediated in every way, by the trauma.
And one reason I think psychotherapy is so important is it's not about excising. It's not a kind of surgery where we cut out trauma or the little bit of, cancer that's there at the core of the person. We cut it out and then they're fine. I think what we're doing is giving them a new way to organize emotion. And this is why treating trauma can take time, why the psychotherapy relationship is so important, why being so close to it and feeling some version of it yourself as a clinician is so important, is you've got a capacity to get a little bit of distance from these feelings. You've got capacity in the room because of how you're there as a clinician to help think about these things in a way that the person fully experiencing them can't, that you're slowly, with repetition and carefulness, helping to build a new way of organizing around these overwhelming feelings. And that's just difficult. And to me, that work is what trauma treatment is largely about. And I think a lot of the people who call themselves trauma informed, I don't know, not all of them maybe, but the way they seem to think, I'm not treating trauma, you're not treating trauma, I think they just disagree. And to me, that just doesn't ring true with anything I've read about the trauma developmentally, neurologically. It doesn't ring true with any of my clinical experience, but that people who call themselves trauma informed seem to disagree, I think, with us.
It seemed to disagree that what we're doing isn't...
You and I aren't treating trauma with this idea that we need to reorganize a new way of dealing with feelings. We need to use the psychotherapy relationship, that treating trauma is kind of treating personality and self. They think that I think we're totally on the wrong track, I think.
Right. Again, so first of all, thank you so much for coming today to have this conversation again. But what we should do next, especially if we get some angry people, which I hope we do, is have somebody who's trauma informed to continue this discussion for trauma part 301. Is maybe we could do a bit of a roundtable, and my hope / my guess would be maybe there's more similarities than we realize, or maybe we could find somebody who's super dug their heels in and staunch and
that's true.
You're saying no, and that there is a technique that we're missing, predicated or incumbent upon some theory that I haven't even been exposed to. But again, it seems a little bit far-fetched in my understanding clinically, like you're saying, in my experience, training, and so on, my literature exposure, my own treatment, and so on. Blah 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 blah. Yeah, it's real, but it's not to say is it so different in terms of its availability or amenability to what we call meaningful psychotherapy.
Yeah, I bet if we actually have this conversation, the reality will be more complicated than what I just said. But I suspect there will still be something to what I said that's important for everybody to hold on.
Yeah, no, I hope we get to do it. Thank you, Kiki, for being here.
I don't know. The name Kiki leaking out into the public, Mac.
Oh, I'll remove. Okay, thank you, Doctor.
Well, no, I don't want you to remove it. I just realized now I need some kind of retaliatory name. Like,
right.
I don't know what I'm going to do.
MaxiPad. They'll call me MaxiPad.
No, it needs to be much better than that. No.
All right, you got to do much better than that. It was a pleasure as always, and we'll see you on the next one, all right?
We'll talk soon.